Welcome to this explainer. We're jumping right in today with a rapid-fire, high-yield review of pediatric oncology priorities. We're zeroing in on exactly what you need to know about cellular regulation and patient safety. So, buckle up, because we're packing a ton of absolutely crucial information into a really short amount of time.
Let's kick things off with a massive clinical hook. Picture this. You've got a kid with leukemia. Their white blood cell count is 2,000, and their absolute neutrophil count, their ANC, is sitting at just 40%. What's your priority action? Seriously, think about that for a sec. This is a high-stakes scenario that perfectly highlights how severe immunosuppression literally dictates every single move we make in clinical care. We're going to circle back and solve this exact puzzle as we move through the material.
Section 1. The Leukemia Threat, Pathophysiology and Assessment. To get why that ANC scenario is so critical, we've got to unpack the actual disease process of leukemia first. You see, we define leukemia as more than just cancer. It's specifically a condition where there's this malignant surge of leukocytes, white blood cells, that are usually stuck in a very immature stage, right inside the bone marrow. It's like weeds taking over a garden. These immature cells multiply out of control, effectively crowding out the good stuff and depressing normal bone marrow function. In that crowding, it creates a really dangerous domino effect. Because the bone marrow is suppressed by all these malignant cells, the patient ends up facing a critical triad. We're talking anemia from a drop in red blood cells, huge infection risks from severe neutropenia, and bleeding from thrombocytopenia. But it doesn't stop there. You're also looking at an enlarged liver and spleen, intense bone and joint pain, and even pathological fractures because the marrow is being heavily invaded. Oh, and keep an eye out for specific neurological signs too, like involvement of the 7th cranial nerve, the facial nerve.
Section 2. Priority Care, Infection Protection, Defending the Immunocompromised Patient. All right, shifting into high alert here. Let's talk about the absolute, non-negotiable protocols for managing a severely neutropenic patient.
Remember that hook question about the 40% ANC? Well, here's the answer. Infection is a huge cause of mortality in immunosuppressed kids, so the rules here are absolute. You must initiate protective isolation. We mean a private room, ideally with HEPA filtration. Anyone walking through that door, masked up, no exceptions. And this third point is highly testable. You have to eliminate environmental organisms. That means absolutely no raw fruits, no raw veggies, no fresh flowers, and zero standing water in the room. You also want to dodge invasive procedures, so no rectal temps and no injections if you can help it. Finally, and this is critical, you strictly withhold live virus vaccines like MMR, polio, and varicella. Giving a live, attenuated virus to a child with a depressed immune system could cause a life-threatening infection. Only the inactivated Salk polio vaccine is okay.
Section 3. Priority Care, Bleeding Prevention. Managing thrombocytopenia. Keeping with that safety-first mindset, we have to talk about protecting kids dealing with severe thrombocytopenia, where platelet production is dangerously low.
We need to build a really solid safety framework here. Yes, you handle the child gently, but you also have to act like a detective and aggressively monitor for subtle signs of internal bleeding. A massive pro tip? Routinely measure their abdominal girth. It's a key way to catch blood pooling in the abdomen early. Now, if an injection is literally unavoidable, you've got to hold firm pressure on that site for at least 10 solid minutes. Also, make sure parents know to strictly avoid NSAIDs and any aspirin-containing products, because those directly inhibit platelet function. Everything about daily care needs to be incredibly gentle. Soft toothbrushes only, ban the dental floss, and tell the child to avoid blowing their nose.
Section 4. Recognizing increased ICP, Crucial Neurological System Checks. Stepping back to the whole body for a second, let's look at what happens when pediatric cancers, like leukemic cells, actually invade the central nervous system and cause increased intracranial pressure, or ICP.
The big takeaway here is that increased ICP looks totally different depending on how old the child is. In infants, their cranial sutures haven't closed yet, so increased pressure literally forces the skull apart. You'll see tense, bulging fontanelles, separated sutures, and something called Maxuin's sign. This is this wild, highly distinctive cracked pot sound you hear on percussion. It was named after Sir William Maxuin back in the 1800s because, well, it literally sounds like you're tapping a cracked clay pot. You might also catch the setting sun sign, where the baby's eyes appear to look only downward. But flip to older children whose skulls are fully fused, and the pressure has nowhere to go. For them, it manifests as severe headaches, super forceful vomiting, diplopia, which is blurred or double vision, and even seizures.
Section 5.
Hodgkin's disease, defining characteristics. Shifting gears just a bit, let's zoom in on a specific lymphoma that tends to peak right in mid-adolescence, Hodgkin's disease.
For this one, the absolute key assessment finding you need to lock into your brain is how the lymph nodes present. You are looking for a painless enlargement. Specifically in kids, you want to hunt for the sentinel node, located right near the left clavicle. This is very often the very first enlarged, firm, non-tender, and movable node you'll observe. It acts as a massive, classic early warning sign.
And listen, if you take away absolutely nothing else about Hodgkin's disease today, please remember this. A positive lymph node biopsy showing the presence of Reed-Sternberg cells is the definitive, gold standard identifier. It's the hallmark that officially confirms the diagnosis of Hodgkin's disease.
Section 6. The NCLEX Challenge. 5-question interactive review. All right, time to test what we just learned. I've put together a rapid-fire quiz based directly on these concepts. Get ready to pause the explainer, think fast, and test your knowledge.
Okay, question 1, coming your way. A child with leukemia has an ANC of 40%. Which item is strictly prohibited in their room? A. Canned peaches, B. Cooked carrots, C. Fresh flowers, or D. Pasteurized milk. Take about 7 seconds to lock in your choice.
And the answer is C, fresh flowers. The rationale here is 100% about environmental infection control. To drop the risk of exposing a severely neutropenic patient to nasty environmental bugs, things like standing water, fresh flowers, and raw fruits and vegetables have to be strictly banned from their room. Moving right along to question 2. Let's see how well you remember those age-specific ICP signs. What is a classic sign of increased intracranial pressure specific to infants? A. Forceful vomiting, B. Macoin sign, C. Headache, or D. Diplopia. Lock it in.
Nailed it. It's B, Macoin sign. Remember, forceful vomiting, headaches, and diplopia are signs you'll see in older kids because their cranial sutures have already fused. Macoin sign, that unique cracked pot sound when percussing the skull, is directly related to the separated cranial sutures we only see in infants.
Let's tackle question 3. Which diagnostic finding is the absolute hallmark of Hodgkin's disease? A. Leukemic blast cells, B. Reed-Sternberg cells, C. Separated cranial sutures, or D. Petechia. What do you think?
Spot on. The answer is B, Reed-Sternberg cells. Finding these specific, characteristic cells inside a lymph node biopsy specimen is literally the gold standard identifier for diagnosing Hodgkin's disease. Almost there. Question 4. To prevent bleeding in a child with thrombocytopenia, what medication must be strictly avoided? A. Acetaminophen, B. Local oral anesthetics, C. NSAIDs and aspirin, or D. Stool softeners. Make your pick.
The answer is C, NSAIDs and aspirin. This comes down to straight pharmacology. These meds actively inhibit platelet function. So if you give them to a child who already has a severely low platelet count because their bone marrow is compromised, it can trigger devastating internal bleeding. Definitely avoid.
All right, final question. Question 5. A leukemic child is scheduled for immunizations. Which vaccine is contraindicated? A. Salk inactivated polio, B. Varicella, C. Tetanus toxoid, or D. Granulocyte colony stimulating factor. Make your final choice.
And the correct answer is B, varicella. Immunosuppressed kids must never, ever receive live virus vaccines like measles, mumps, rubella, or varicella. Their bodies simply can't fight off the attenuated virus, and it can easily lead to a life-threatening infection. Stick to inactivated vaccines like the Salk polio vaccine to keep them safe. Well, that officially wraps up our rapid-fire review. Before we go, I want to leave you with this final provocative thought. Now that you know exactly how fast a pediatric patient's status can crash from a low ANC or the significance of an enlarging sentinel node, how are you going to actively apply this priority framework on your very next shift? How will you make sure no subtle warning sign ever goes unnoticed on your watch? Think on that, stay sharp, and keep learning.